three major shortcomings of the CDC's pandemic response. First, the CDC leadership downplayed the serious impacts and aerosol transmission risks of COVID-19. Second, CDC leadership had aligned public guidance with commercial and political interests over its own scientific evidence in many cases. And lastly, CDC guidance focused on individual choice rather than emphasizing prevention and equity. I'm going to show you some examples now in those various areas. So, I think that this was a feeling that we all had watching the CDC guidance, but it's really interesting when you sit down and you actually look at the CDC's Twitter communications, which allows an in-depth and really quantitative look at the way that the CDC is communicating this information. And, I will say I have received feedback from reviewers saying, well, not everybody looks at Twitter. This is probably not representative. And overwhelmingly, the Twitter communications very much reflect the other communications that the CDC was putting out there in the messaging that it was communicating to the media. So during the respiratory virus season, before the end of the public health emergency, the CDC tweeted 101 times about COVID, in comparison to 401 times about the flu. The CDC also has an @CDC flu account. It doesn't have any such account to talk about COVID. And also overwhelmingly, the CDC has emphasized vaccines, right? 61.4% of all tweets about COVID and 46% of tweets about flu are talking about vaccines as a form of protection. Vaccines are very important. They do help to protect against long COVID. But masks are also really important and are much probably more effective actually than vaccines at preventing COVID infection. But masks got only 2 tweets as compared to hand hygiene and covering your cough, which also got 2 tweets total. And so again, we'll see just that the CDC is tending to emphasize these measures that are much less effective at preventing transmission of COVID-19, which is airborne, with CDC Director Walensky emphasizing good hand hygiene, cover your cough, is really not that effective at preventing COVID, which is, suspended in the air, and it's much more effective when you're wearing masks and using ventilation and other tools in our toolkit to layer protections to prevent COVID transmission. Also, CDC, as our speakers have already started to introduce, downplays the serious impacts of COVID. The CDC emphasized the serious risk of illness and death from the flu much more than COVID, regardless of COVID causing more deaths and hospitalizations. So you can see here that overwhelmingly, again, the CDC really focuses on this message about older adults, immunocompromised adults, people in special categories can become severely ill. When you take a look at the communications coming out of CDC about the flu, it's actually very different. They communicate to the general public, and they even present these messages about how people are at serious risk. Anybody can become, healthy people can become sick with the virus. And then there are even individual stories of people who were harmed. They also talk a lot about the deaths of the flu, but they don't talk about COVID deaths. There were 0 tweets in that time period talking about childhood deaths from COVID, as compared to 25 tweets talking about child deaths from flu in that same time period, even though actually more children died from COVID than the flu in the same time period. And again, many more people were died from COVID than the flu in last year's flu season. Similarly to the data that Dr. Rhodes presented, again, we're seeing the same this year, and more people were hospitalized from COVID than the flu. And just some examples of these CDC communications. This communication that says the flu can be serious, talking about how this one woman lost half of her lung due to a flu infection. No such tweets about COVID. The CDC during flu season sends 1 tweet a week, letting you know about how many children died from the flu. They even send tweets when only 1 child dies. Again, no such reminders about COVID. And then these flu burden estimates that are also sent out weekly. Again, no such estimates about COVID. So it's no wonder that the public wants to quote unquote move on. They also don't have all the information to make those decisions for themselves. Again, we've heard this over and over, but this idea of the CDC scientific interpretations being influenced by commercial and public interests, just a reminder about when the Delta CEO asked the CDC to cut the quarantine time, and then shortly thereafter, the CDC did so. It's really difficult not to think that that had some influence. And CDC guidance has also shifted following politicized representations of public opinion. It's really interesting to see in mid-February 2022, this was something that had been circulating a lot on social media. A memo had reportedly circulated in the House and Senate Democratic campaigns from Impact Research, which is a Democratic polling firm, which recommended that Democrats should declare the crisis phase of COVID over and push for feeling and acting more normal. And strikingly, a couple weeks later, when President Biden delivered his State of the Union address, it contained a lot of similar language. But most interestingly, poll data from the same period showed that most Americans believed the pandemic was not under control and still supported pandemic mitigation measures. Remember that in 2022, it was right after the Omicron surge, when the hospitals had been overwhelmed and ambulances were circulating for hours, being unable to place patients in ICUs. So people were reasonably still concerned. I just want to show you a graph of that poll data, which I think is just really interesting. You see here, and people's concern about masks, people's concern about COVID, really ebbs and flows where, especially it has a lot to do with how many cases there are out there, which makes a lot of sense. So, a lot of people were still concerned that COVID was a great risk. 40% of people here January, February of 2022, believing that COVID actually was high risk, right? And then, so like very few people believing COVID was of little or no risk. And then, as the numbers started to decrease, sure, that number, fewer people are thinking, are more and more people are starting to be less concerned. But then once the CDC made this declaration, oh, you know what, no need to wear masks, and then all of the employers took away the mask mandates, that resulted in a sudden shift. It preceded a sudden shift in public opinion. And this is just to say that the CDC keeps saying, we're just meeting people where they're at. But the point is that the CDC is shaping public opinion by making these public declarations. And when they say, when they make a big change, they're really communicating it is safe to do this. And that's not really the full message. The full message is a little bit more complicated than that. And people need the full information in order to make their own decisions. Again, also the CDC is favoring individual choice over prevention and equity. So this expectation that people are going to make their own decisions, that they have power over, their circumstances in order to protect themselves. When Evusheld ceased to be authorized, the CDC recommended that people make their own individual protection plans. CDC has repeatedly communicated things like your health is in your hands, get vaccinated. And of course, with an airborne virus, nobody can protect themselves alone. And this was a theme in the comments that we heard from the people who gave us, quotes in response to our survey, with many disabled people communicating that they have been homebound and that as the CDC has removed layers of protection, they're not only finding it difficult to protect themselves because they're, rationing N95s because they're expensive, but also postponing medical appointments because it's really difficult to protect oneself and becoming even more and more isolated from friends and family. And so in conclusion, we have some overarching recommendations for the CDC from that report. And of course, from this group today, I think we're offering the same recommendations, just saying that the CDC has a duty to provide policymakers and the public with high quality evidence to promote public health. And that means communicating the science to the public is really what the CDC needs to be doing. Partnering with institutions and communities to create conditions that allow people to protect each other and make public spaces safer for all. And lastly, a plan to protect everybody, especially the most vulnerable, will be better in the long term for people, the economy, and future generations. And so, in sum, we are really here today urging the CDC to create a public accountability process to ensure that you're really engaging with the public as you make these policies, which really do shape people's ability to protect themselves from disability, serious illness, and death. And thank you to all of the wonderful people and organizations that helped support this effort. Thank you so much.
Thank you, Lara. Thank you so much. What a powerful report. And I just encourage everybody to please check out the People's CDC external review to be published in the American Journal of Preventive Medicine. I believe that Lara already put the link in the chat. It is a thoroughly, very comprehensive report. And I also want to make note that the way that the CDC is approaching the pandemic makes an assumption that the public can't understand the science and what's going on. And we actually believe that the public is perfectly capable of understanding the science if it's broken down clearly, if people understand this is a novel virus, and recommendations may change based on our increased understanding about how this virus actually operates. But we know the death, morbidity, mortality that COVID-19 continues to wreak havoc on our populations, and particularly as it relates to long COVID. We're not going to reach the level of trust that's necessary without an honest accounting of recommendations that correspond to the science that's actually being produced. So with no further ado, I have the honor of, and thank you again, Lara, thank you so much, of introducing Lisa McCorkle, Masters of Public Policy and co-founder of the Patient-Led Research Collaborative. Lisa, thank you so much for joining us.
Thanks for having me. As Rita said, my name is Lisa McCorkle, and I am a co-founder of the Patient-Led Research Collaborative, which is a group of people with long COVID and other infection-associated chronic conditions who conduct research on long COVID and advocate for better policies. Tomorrow marks my 4-year anniversary of having long COVID, and on Friday, as an international community, we mark International Long COVID Awareness Day. At least 17 million American adults and millions more children have long COVID, with people of color, transgender people, and disabled people at higher risk. As COVID continues to spread, with reinfections increasing your risk for developing long COVID, vaccines having minimal protection, and most long COVID cases onset from an initially mild case of COVID, the number of people with long COVID will continue to grow, now faster with the CDC guidance lowering and in asymptomatic cases, removing isolation protocols. And with shortened isolation periods, people will not get the rest that they need to adequately recover, which also increases your risk for long COVID. We are very much still in a pandemic. There are still hundreds of deaths per day from COVID, and we are not at a place in our long COVID response to roll back COVID protections. Recovery rates for long COVID are low. One study found that after 2 years, less than 8% of people with long COVID were fully recovered, and there are no FDA-approved curative treatments. Millions are unable to work and attend school. Our social safety net, including disability benefits, are often failing people with long COVID. Lowering the isolation period for symptomatic COVID and removing it for asymptomatic COVID is not based in science. We know that peak COVID infectiousness can vary from 2 to 5 days after an infection begins, and yet this policy does not account for this. While I appreciate the aspects of the guidance for what to do if you have the flu, RSV, and other non-COVID respiratory viruses like masking and improving ventilation, without isolating during peak infectiousness for COVID, this guideline will cause preventable deaths, disability, and reduced quality of life. As we recognize Long COVID Awareness Day on Friday, I urge the CDC to be aware of the reality of long COVID and to reevaluate and enact equity and science-based policies. In addition to putting in place guidance that reflects the science, the CDC must have public communication on the risks of long COVID in adults and children, as 1/3 of the public still has not even heard of long COVID. We need public communication on encouraging masking while sick and on the risks of COVID reinfection, including the risk of developing long COVID after reinfection. The CDC must continue and expand the tracking of the incidence of long COVID. The CDC must ensure that there is mandatory masking in healthcare settings so that people have a better chance at accessing needed healthcare without risking their health. The CDC must facilitate improvements in indoor air quality in public spaces, especially in schools and healthcare settings. And the CDC should ensure that COVID rapid tests are widely available to enable detection of infections, with negative rapid tests 2 days in a row being the sign that one's COVID isolation can end. As I mark my 4-year anniversary of having long COVID tomorrow, I am disheartened. My community has not just been left behind, but neglected. We are not safe in this world, and as a result, unfortunately, more will join us, and we will get worse. After 4 years of a pandemic that devastated communities, I wish that as a society, we would have finally learned to live the values that we claim, that we would have implemented policies that value the lives of the immunocompromised, of disabled people, of poor people, of people of color. For those who have lost their lives to COVID and long COVID, it is too late for CDC to change its course. But I desperately urge the CDC to hear our call and to do what is very much in their power to do to increase the isolation period and adequately respond to this crisis. There's really too much at stake. Thank you.
Lisa, I want to thank you so much for your moving presentation, and we share with you the pain, the grief, and the trauma that long COVID is causing for millions of us in this country and indeed worldwide. It's part of, I think, an ongoing narrative that is wrapped around dehumanization, a normalization of death, dying, and sickness that must be combated so that we as human beings can enjoy life, enjoy world, heal the earth, and actually develop relationships with each other as opposed to corporate interests dominating our lives. Thank you so much, Lisa, for your presentation. We really appreciate it. And now I have the honor and pleasure of introducing Raj Chekslashaya. Raj, if I pronounced your name wrong, please say it again. I'm so sorry. Raj is a PhD candidate. He's the unit chair of the United Auto Workers Local 2865 at the University of California, Santa Barbara. And I'm assuming very active in the UCLA strikes last year. Thank you so much for joining us today. Raj, the floor is yours.
Thank you, Rita. And it's Raj Kaglashia, but it's okay. Everyone is okay. So, today I'm going to be talking about how COVID affects our freedom to live our lives and how that interacts with our ability to even work. So, public health gives us the freedom to pursue our dreams and to care for our families, our friends, and our communities. Without it, that freedom is threatened as we are constantly in an environment where long-term illness is the only one wrong breath away from taking away that freedom, rendering us incapable of helping those we care about and pursuing our dreams in life. Let's take labor, for example. We work in order to sustain our families so that our children can have a future and to save up enough money to pursue our higher goals. Thus, our ideal working environment needs to be one that enables that freedom rather than takes it away. Threats to that ideal working environment are labor issues, and at these unit share, I've seen many workers screwed over by our university on many issues, from wages to disability issues to international student issues. There's a wide variety of issues, and public health is one of those issues. And a major ongoing threat to this working environment is our ongoing pandemic in the face of the destruction of public health. COVID is a labor issue. 1 in 10 COVID infections result in long COVID, a multi-organ disease with no known cure, and 61.8% of California farm workers now have long COVID as a result. Our most vulnerable coworkers, those with disabilities, those who are older and younger, and those who are at high risk, are constantly put in life or death situations whenever they have to go in person to a workplace with no mask. And repeat infections weaken the immune system, causing all of us to become high risk and become more susceptible to other viruses, as the recent RSV outbreaks in children have shown us. And make no mistake, every single one of us falls under the high risk category right now, as that category is very broad. People who are overweight or obese, people who are pregnant, people who are physically inactive, and even people who have gotten infected by COVID at least once. If the CDC follows through with their continued destruction of public health by taking away the 5-day isolation period that stands in between life and death for so many of us, then our freedom to pursue our dreams and care for one another will be further taken away from us as the air we breathe becomes more stuffed with this dangerous virus. And it is a double whammy in that it makes our own workplace even more dangerous to our health than it already is, making the place where we're supposed to earn the income necessary to sustain our families even more of a place where we instead get long-term illness that takes away our ability to get that income in the first place. And what is the reason that the CDC is giving for taking away our freedom? And it's justifying it by saying that we do not have enough sick leave to isolate. But that too is a labor issue. Paid sick leave enables our freedom to live the healthy lives necessary to pursue our goals and help our communities by making sure that infectious people can stay at home without worrying about their pay getting cut, so that we can work without getting sick with a disabling virus. If the CDC actually cared about public health, then they would champion paid sick leave as something that should be mandatory to protect these freedoms. No, the real reason why they are taking away our freedom is to protect our bosses' freedom, to make us go to work sick so they can squeeze every last dollar from us. And in the case of those of us workers who are at most risk, they want our deaths for their dollars. It is unsurprising but disappointing that the CDC cares more for our employers' freedom and lives than the freedom and lives of the common people. This is why we organize together as workers to form labor unions. Our bosses and elites may be powerful, but we outnumber them, and they are scared of our numbers. We can and must pass resolutions for guaranteed sick leaves in our union contracts. We can and must fight for provisions for clean air, masked workplaces, and free and fast PCR and rapid tests. We also need employers to meet workers' accommodations requests without having to jump through the burdensome hurdles, provide medical documentation in a world where many long COVID patients are gaslit by misinformed providers about their sickness. These are all things that are not only possible, but are already underway in our struggle. University of Michigan graduate student workers, for example, won the right to request students to wear masks and to request remote teaching in their contract last year. Over 500 workers in the UC system signed a petition calling on our bargaining team to add a public health article to our union contract during the 2022 academic workers' strike. And even though they did not ultimately end up doing it, our union was eventually pushed by us to create a UC-wide public health working subgroup to address COVID issues. And in Arizona, workers have recently won the right to workers' compensation for getting COVID in the workplace. We can draw from the lessons of the 20th century workers' struggles to make workplaces no smoking zones. For example, flight attendants organized and won this right to protect their health freedom through their union organizing in the 1980s. And of course, I encourage the CDC scientists who have been releasing critical MMWRs, or monthly and mortality weekly reports, on the science of COVID to themselves organize as workers internally to do their duty of protecting our public health freedoms against the unscientific and freedom-robbing policies like the elimination of the 5-day isolation period and the stance that paid sick leave that is not necessary. This could, for example, be done through the Federal Workers Union, the AFGE. Always remember, our employers are afraid of our power in numbers. If we organize, then we will win. And we'll get back our public health that gives us the freedom to pursue our dreams and care for our families, friends, and communities. Thank you.
Thank you so much, Raj. You remind me and you make us realize that we are a part of a very large working class, whether it's doctors working in academic institutions, auto workers in unions, in factories, and in universities, whether it's nurses unionizing like gangbusters, even in the South, which is where I'm from, in Georgia. Gig workers, graduate students organizing, all of us together, whether you're in the meat packing industry or a poultry worker, a farm worker, a physician, a PhD, a scientist, we are all part of a big working class. And this is whom the CDC should be, the leadership of the CDC should be responsible to. And it should also be responsible to its own workers who are producing excellent science, but then are gaslit by horrific recommendations. Starbucks workers, Amazon workers, workers throughout the country are unionizing to gain strength that we know is so important to launch a political motion in this country that changes from a death narrative to a narrative of love of life, love of humanity. Thank you so much, Raj. And now it is my pleasure, my distinct pleasure, to introduce Gabriel Sand Emeterio, Masters of Social Work and one of the leaders of the Long COVID Justice. Gabriel, take it away. Thank you, Gabriel. And thank you again, Raj. Gabriel, you're on mute, my dear.
Can you hear me now? I guess you can you hear me now?
Yes,
I'm
yes.
unmuted. Okay, great. Hi, thank you for organizing and holding this forum, and thank you for including me. I'm Gabriel Sanemeterio, the co-founder of Long COVID Justice, and I am here as one of the millions of chronically ill and disabled Americans suffering from long COVID. And and I am also a member of the communities most disproportionately affected by long COVID, which are Hispanic adults and LGBTQ people. Additionally, I'd be remiss if I didn't name that Black Americans, women, and low-income people are also disproportionately affected by long COVID. The current change to the CDC's shortened COVID isolation guideline is factually wrong, morally wrong, and practically wrong. It is factually wrong because according to the latest data in the Household Pulse survey, long COVID rates have actually gone up from 5.3% to 6.8%. And let us not forget that it takes time to develop long COVID symptoms, for the people affected to identify their symptoms, and likely even longer for such individuals to get a diagnosis and be counted as having long COVID. Moreover, we just experienced a winter surge of COVID, and we don't know yet the number of people who will go on to develop long COVID from this most recent peak of infections. Long COVID can occur as a continuation of illness from the acute phase, or it could take months to reveal itself and look very, very different from acute COVID symptoms. People who just had COVID in the January surge may just be starting to recognize symptoms or that something is wrong, and it may take months for them to realize that they have long COVID. Long COVID symptoms can also fluctuate, adding to the complexity. Thus, a period of remission may not mean full recovery. This new guidance is morally wrong because it leaves behind and threatens the well-being and the lives of the most vulnerable people, including those who don't know themselves to be vulnerable. According to the CDC, 60% of American adults have at least one chronic condition. This is a sick nation, and rolling back protections will only make us sicker. Yet the CDC says long COVID rates are going down in their justification for the change in the guidance. But CDC's own data from the Household Pulse study shows that long COVID rates actually went up. Adults currently experiencing long COVID, a full quarter of them who are experiencing significant disability and limitations. Why is the CDC justifying this harmful change on the backs of people with long COVID, which is contradicted by their own data? Lastly, the guidance is practically wrong because many people who are already sick and continue to be sick have less of a chance to get better if they get reinfected multiple times. The CDC, on behalf of the Biden administration, is not doing what they should do to care for the general population. If they cared for us or about us, they would be providing education on long COVID and the many potential risks posed by even a mild or asymptomatic COVID infection. They would conduct case finding, the public health practice of helping to identify who has long COVID and connecting them to help. If they cared about the people, the CDC would be providing support, particularly for those communities disproportionately affected by long COVID. They would be providing widespread provider education so that we would not be shamed, gaslit, or even given bad advice when we seek help. The CDC should not be taking protections away. Instead, they should provide guidelines that allow people to rest when sick with COVID or any other illness for that matter. However, the CDC is creating the conditions that are detrimental to public health. Even if not a single new person got long COVID today, we have millions of people, children, adults, and seniors already sick, and it is doubtful that they will fully recover. How could we? We don't have significant resources in comparison to the level of need, and we don't have even treatments available. It is still unclear how effective vaccines are in preventing long COVID, and helpful as they may be, vaccines have become harder to access, and vaccine uptake has been reduced. Only a minor percentage, roughly 1 in 5 Americans, have gotten the current vaccine that offers the best protection for strains circulating today. What we need from the CDC is much more public education on long COVID, effective case finding and tracing for long COVID, training for medical providers to end the gaslighting of patients, and to identify and diagnose long COVID effectively to provide patients with managing techniques which often require rest. We also need better data and clear information on the dangers of COVID reinfection. We need funding to engage with community groups and support education efforts on long COVID. We need the CDC to encourage cities and states to uphold masking in healthcare settings to protect providers and patients alike so that medical appointments are safer. We need to greatly expand legal and social support, a robust safety net not limited to disability benefits to keep people from sinking into abject poverty. The CDC and the government as a whole could do all of this, but instead, they're choosing to put us in harm's way by equating COVID to the flu or RSV. Let us be reminded that COVID does not follow seasonal patterns like the flu, and that new data shows that how COVID affects the immune system, making people more likely or more susceptible to getting sick. COVID also increases the chances of experiencing adverse cardiovascular outcomes, and by now it's been proven that COVID can damage the brain and the nervous system. What else will we find out while COVID infections are allowed to run rampant? Yet we are told that it is okay to get sick and get others sick. We have a name for what the CDC is spreading: misinformation and disinformation. Thank you.
Gabriel, that was absolutely brilliant. I just want to thank you so very much for sharing your story and pointing out something that I think we often forget, or we're often told, well, we just don't have the resources. No. The resources are available. We have an abundance of resources. What we don't have is equitable distribution of resources. And, it's also interesting to note that just a few years ago, the former director, Walensky of the CDC, basically declared racism, white supremacy a public health emergency, right? And so how can we now double down on the inequity that's being recommended in terms of cutting isolation period, making it difficult to get tests, expensive tests, very difficult to get Paxlovid. A number of obstacles are placed in the way, not to mention that after the 1 year ago this May, the public health emergency was ended, which has resulted in over 17 million people losing their health insurance, 70% of those for logistical and paperwork reasons. So yeah, we have a crisis. And as Gabriel said, healthcare, not warfare. Absolutely. The resources are there. Let's make sure that they do the job. I want to now open our conversation, and perhaps we can have a full screen, Kendra. And also, I do want to take this opportunity to thank Kendra Tillman, who works with the People's CDC, for her logistical work, for making the slides come up so effortlessly and beautifully, and for moving us along this very important conversation effortlessly. And once again, thanking all of the presenters, Dr. Kim Rhodes, Rosalind DeLeon Minch, Dr. Lara Jimenez, Lisa McCorkle, Raj Chalashki. I'm butchering that again. I'm sorry, Raj. And Gabriel San Emeterio for the brilliant presentations and the common threads that we're saying. Again, calling for the leadership of the CDC to revisit the abrupt elimination of isolation guidelines, to open CDC guidance to a public comment period, and above all, to make the CDC, to reorganize indeed the CDC, to make it transparent and accountable to the public and community groups, not corporate interests, not hospital groups, not insurance companies, and not big pharma, who've been dictating the responses to this. I'd like to ask, I don't know if we have press online here. I'd like to ask if there are any questions to the panelists, if you'd like to put them in the chat, and if there's a particular panelist you would like to respond to your question, please feel free, and we'll take just a few minutes more for Q&A. I believe we had, let me go back a little bit here. We had a question from Kaya. Is it, if I may, Kaya, is it legal for the CDC to make changes that aren't supported by scientific evidence and goes against established evidence-based standards, especially without public, and when it puts everyone in active risk of death? Would anybody, I don't think we have any lawyers involved here, but would anybody like to respond to that question? Rosalind, I'm going to ask, is it legal for the CDC to make recommendations that contradict the science?
That's a great question. I'm not sure that I can answer that fully, but I can tell you that the CDC's advisory committee, known as HICPAC, it is supposed to be, made public in terms of, their what they're doing, and they're still not providing input, which is one of the concerns that we have been pushing, is for them to make things much more transparent, and to really engage the active involvement, input of frontline healthcare workers, especially nurses, who will be most impacted by these guidelines, these updates that they are proposing in healthcare settings.
Thank you, Rosalind. I see Lara has her hand up for a brief answer to the question too.
Sure. Yes. Yeah. I just wanted to also, echo what we've been told over and over as we've thought about ways to challenge some of these protocols, in particular, the way that they violate the ADA protections, the Americans with Disabilities Act protections that prevent public health, public spaces from being accessible. What we're told is that the CDC as an institution, in some ways, its declarations are taken as science at face value. And so that's specifically why, in spite of what scientific evidence may demonstrate, it would be very difficult, or, that would be one of the challenges of proving in a court of law that a particular guideline created conditions that violated somebody's rights. So it is actually, it's complicated, but there, our understanding is that there's it's not totally clear. And I think part of it is the way that also academic organizations have also come out behind some of these guidelines, that makes it more challenging for us to challenge them legally.
Thank you. I'm going to recognize Lisa briefly, and then I want to get to another question. Lisa, please share with us.
Yeah, I just wanted to point out that, I think with this guidance, one of the unique aspects of it is that they paired it with background. So they have this background document that they released when they released the guidance, that I think in their view is saying, look, we're following the science, and it's like, this is how we came to this decision. But they're very selective with what science they're following, and leaving out a lot of, basically all the science that we've talked about today on this call. And so I think, their argument would be, we are following the science, look at our background document, but they're really just being very selective on what makes their argument for them.
Thank you so much, Lisa. Thank you for that. I see an earlier question from Ann Hunter that I'm going to ask Dr. Rhodes to reply to. Ann asks, since COVID is less seasonal than the flu, the comparison would be even more dramatic if you gave the numbers of the hospitalizations and deaths for a full year. Yes? Dr. Rhodes?
Sure. So I did respond to that a little bit in the chat. I don't think it was exposed to everyone, but from my perspective, I think the answer to that would be, maybe, because what that misses, if we just look at deaths over the course of 1 year, is the clinical impacts that are not seen in hospitalization, for example, and quite frankly, death is too far downstream. The goal of the CDC is not just to prevent deaths, it's to prevent all morbidity on the pathway to, the place that we ultimately all end up. So what I think that misses, if we just count the deaths, I mean, we're basically getting in the bus with the CDC, right? The CDC is saying that we need to use hospitalization and death as our endpoints, and that completely overlooks everything that happens in between and how the clinical manifestations of long COVID, for example, reduce workforce, our labor workforce, reduce people's capacity to actually do their jobs. So there are folks who maybe, have serious cognitive disability, but cannot afford to be off work and may not, have the label of having a disability. And I think that's another piece that I don't know that we've talked about. Like, do you get a label of being disabled and protections under ADA for having long COVID? And if you don't, then you're going to work. And if your capacity to actually do your job is impaired, there are some other impacts that are going to happen that we're going to see as a country, as a sort of a global community, in terms of impacts that we saw, I think, in 2020 on supply chain, for example, right? Mm-hmm. And I think we're starting to see a little bit of it now. The part that concerns me is in air traffic control. Like, those are folks we need to be working at the tippity top of their capacity. So we're going to see these impacts in different ways. It's not just about death from COVID. It is actually about the impairment and the maiming of the global community, and how that's going to then play out in how we receive and experience, and interact with the systems that are not just about healthcare, but are economic in our world. And I just also want to put a pin in the impact on the healthcare workforce, because that's also a place where you don't want people working not at their capacity. Those mistakes are going to lead to other kinds of negative outcomes. So I'm not sure that just counting deaths is the right way to go. And I hope that we're trying to prevent something more than death as a public health institution.
Thank you so much, Dr. Rhodes. Thank you. And I see that we're going to try to end in just a couple of minutes. I see that Rosalind has a comment that she'd like to add to this as well. And perhaps, too, Rosalind, you might speak a little bit to what Dr. Rhodes was talking about in terms of the supply chain and how necessary PPE was withheld from healthcare workers, and our hospital corporations essentially made it very difficult to have the kind of supplies that were necessary during the heights of the pandemic, and still to this day. It's frightening to me to go into a hospital where, by definition, people are potentially ill, sick, immunocompromised, elderly, and face a maskless healthcare provider. Very dangerous. And I know that here in Atlanta, we have some campaigns going to put masks back on hospitals, even as governors in the South threaten to withhold funds from institutions that implement mask mandates. So we've got a heck of a struggle going forward. But with panelists like this and people that are listening on this call, I have nothing but optimism and joy about our ability to win the kind of public health infrastructure that we actually deserve.
Yeah.
Rosalind, you
Yeah.
want to comment? Thank you.
Yeah, thank you so much. So 2 points I want to make very quickly here that, studies are finding that for many folks who have long COVID, they had a mild infection. And so I think that while we are seeing the household pulse survey, an increase in long COVID prevalence, I think that's incredibly, an undercount. It's an underestimate because there are many people out there who had either an asymptomatic infection or a mild COVID infection that they may not tie their symptoms, with long COVID. And to your point, we are seeing, there's a healthcare staffing crisis in healthcare right now because of these unsafe conditions that nurses and other healthcare workers have had to endure since the very beginning of the pandemic, because of these weak CDC guidelines, right? And so, in the very beginning of the pandemic, nurses were told that, wearing a bandana is okay for you to take care of someone with COVID, and a lot of which resulted in a lot of an untold number of healthcare workers and nurses dying from this disease. And 5 years into the pandemic, we have ample scientific evidence that COVID is absolutely an airborne disease, that COVID is far more dangerous than the flu, and still to this day, we have surveyed nurses since the very beginning of the pandemic, before it was even declared a pandemic. And survey after survey shows repeated failures of healthcare employers across the country not providing, protections that nurses need. Nurses who are the frontline response to everyday infection control, to pandemic situations. And 5 years into the pandemic, they are still not getting the respiratory protection and other critical measures that they need. And because of that, healthcare workers, nurses are leaving the bedside. And on top of that, many of them are experiencing long COVID symptoms. And yeah, you're absolutely right, Dr. Rhodes. This is, another healthcare workforce that we need to protect, because the most vulnerable people go to the hospital to get care. And these hospitals, they need to be centers of healing and not centers for people to get infected even more.
Thank you so much for that, Rosalind, and the passion with which you're talking. This is not an academic exercise. This is people's lives and their livelihoods. So thank you for that. And I'm going to recognize Gabriel. Gabriel, I was going to have you close us out, but I see Lisa's got her hand up too. So Lisa, you'll be tasked with closing us out. But Gabriel, you beautiful human being, please.
Oh, yes, thank you. I just wanted to say that we really need legal protections in schools and in the workplace, because long COVID is much more than just cognitive impairment. It's a lot broader than that, but cognitive impairment, the brain fog, has gotten a lot of attention, and there's a lot of stigma around it. So folks are afraid of disclosing that they have long COVID to their employers for fear that it may impact their careers. Additionally, having the ability to rest or to take intermittent leave or to have various accommodations, whether it's an educational setting or work setting, can help people minimize the impact on their cognitive impairment. So yes, it is very important that we eliminate the stigma and protect workers and students from potential retaliation from disclosing that they have long COVID and requesting accommodations.
Thank you very much. I certainly remember the days that I was working in the HIV clinic at Grady, and the way that patients were discriminated against that had HIV. And with that, I'm going to ask again my good friend, Dr. Lara Germanis, to close us out. And before I do that, I want to take a moment just to thank Kendra Tillman for making this go so smoothly today. Mary Germanis for also helping with all the technical expertise of which I completely lack. And above all, thanking all of the panelists for joining us and all of the participants. And please, please stay in touch with us, stay in touch with the organizations that are listed in the press release, stay in touch with the People's CDC, that's info@peoplescdc.org, and we will be getting back with you all too. Just a wonderful wonderful series of very informative and passionate and necessary presentations because, you know, we not only need another world is possible, it's absolutely necessary. And with that, Lara, please close us out.
Thank you so much. And of course, kudos also to Rita Valenti, who's done such a phenomenal job, facilitating us and bringing us through and emceeing this press conference. And thanks so much to all who joined us. I just wanted to make a note that it was really interesting. I've learned lately that the federal government and, I believe it's something that may be either coming from at least the state government in Massachusetts with public payers. I'm not sure if this is something which is happening at the federal level yet, but at the federal level, the Centers for Medicare and Medicaid have a lot of health equity programming now and are requiring hospital systems to demonstrate that they are asking patients and documenting and offering things like language access, asking about sexual orientation and gender, asking and documenting different kinds of questions and demonstrating that they are serving patients. And so it's a really a process that seems to be at the beginning. And it's something that I'm looking into more, but I think we should all be trying to figure out whether it is happening in our states or if it's at the federal level, because at least in Massachusetts, there are going to be these requirements to ask people about disability, then also to demonstrate that we're meeting access needs at hospitals. So this could be a really key opportunity for people to advocate for masks or masking accommodations as a disability right, at least in healthcare facilities. So just want to flag this, encourage people to join their patient family advisory councils at hospitals. All hospitals and community health centers are required to have them. And just want to reflect specifically on the experience at the health system where I work, which is, with the only public hospital system in Massachusetts, and where the leadership had a different approach to masking after the public health emergency was ended, which was to say, that we are going to offer to patients the ability to request masks, and we don't expect any paperwork or, all you have to do is say it. And so there are signs at the front desk that say, ask me to wear a mask if you'd like one, and to try and, say, well, there's this thing also in healthcare. I just, the more that we can be using the language of the hospitals to be, to be advocating for these very basic protections, I think the more effective we'll be. We have the quadruple aim, this expectation that we're supposed to be improving population health, reducing costs, enhancing patient experience, right? So enhancing patient experience is one of the four pillars of the quadruple aim, and the fourth one is, improving the healthcare worker experience and reducing burnout. So just, asking them to sort of meet their own objectives. And, I'm hoping that at least my health system will be able to have something written to present and share as an innovation in the way to make it possible to allow and enable patients so that people don't get this ridiculous jumping through hoops to ask for something really basic, which is that you shouldn't have to catch COVID when you're getting healthcare. And just once again, thank you all so much for joining us today, and to our excellent speakers and our excellent MC, and onward.
Thank you again. Goodbye, all. Take care. Much love, and we'll see you all soon again. Take care. Bye-bye.